throwing more into the mix here, of course, we also have CAR T, we have BiTE. I'd love for you to talk about those options and how they work for patients and caregivers who don't know much about them.
Yeah, no, thank you. So one of the areas where we have the most excitement is this whole field of CAR T cells and the bispecifics. For background, we all have T cells in our bodies. Most of the cells that circulate in our blood that belong to the family that are called the lymphocytes. And for patients who know about this, you know that we measure the neutrophils, right? It's the most common one, especially if you went through transplant. You know very well what the neutrophils are, or the so-called ANC. But if you look at the blood counts, the next one you'll see is lymphocytes. And most of those lymphocytes, at least 70 to 80% of those lymphocytes belong to this family that are called the T lymphocytes, so the T cells or the T lymphocytes. Now, these cells are natural bullies. They are just total bullies. And what happens in our body, if the T cells kind of go around and you want to get out of its way, because if a T cell latches onto something, it just starts attacking. So it's kind of looking for areas where it can help. So they help the human body fight off, certain infections and in protecting us against tumors. That's the main role of T cells, and they're part of our immunity. We even have heard about this with COVID, of course, right? But so someone came up with the idea of saying, well, if they are bullies, what if we make them go after myeloma cells? What if we prime them to go after myeloma cells? So with the advent of genetic engineering, people thought, well, we can take them out of the body. We'll reprogram them so they have anchors that match those that exist in the myeloma cells. And then we'll give them back into the body. And, 15 years ago, this was science fiction. And, people were not too convinced about immunotherapy back then. And it turns out it works. So if you give back T cells to someone, they go in, they get infused, they grow, they expand. So they divide. And they start forming a rebellion against the myeloma cells. So those are what we call CAR T cells. The process is, takes a few weeks. So, a person who's a candidate, you collect their T cells, they're sent to a facility where they are processed, and then they're infused back into the person, and they do their thing. And it's usually a one-off thing. And I use the analogy of, that fable of, the frog that has been asked by the scorpion to cross the river, right? And it ultimately convinced it. And as soon as the scorpion is on top, it stings. So that's the nature of T cells. T cells do that, like the scorpion. So that's all good and well. But then someone else said, well, if we get the T cells out, what if we, instead of getting the T cells out, infuse something that works like a matchmaker, so something that brings together T cells and myeloma cells. So there's happy T cells circulating there, and if we put them next to myeloma cells, we know they're bullies. They're going to go after them. So that's what the matchmaker. Those are what we call bispecific antibodies. So these are antibodies that on one arm they attach to the T cell, and the other arm they attach to the target cell. In this case, myeloma. I describe them as well too. They're like double-sided Velcros. One of the Velcros attaches to the myeloma, the other one to the T cell. And it turns out that we have several of them that are highly effective. I believe we had about 7 of them that were presented at the ASH meeting. And the potential advantage over CAR T cells is that, they're off the shelf. So, you get to the clinic, you need treatment, you mix the antibody and you infuse it in the person without having to wait for that engineering process. So just hang on to your seats. That will be a battle that will be happening over the next several years as to what is better, the CAR T cells or the bispecifics, but ultimately for the good of patients, because this is going to be one of the ways in which we treat myeloma.
It's still in research now, and we don't have a crystal ball, but we do know some of the pros and cons, right? From what I'm hearing, for instance, CAR T does maybe take a little longer because you're having to take the cells out and send them somewhere and then put them back. Whereas with the bispecifics, you're able to do it sort of in-house. Can you talk more about what we do know right now about how you would weigh the pros and cons with both of them?
The reported pros of CAR T cells are that they have a greater track record, and because their ability to expand and their ability to persist, they could be a one-off treatment that does it. And in fact, we have long-standing responses and histories. I mean, there was that patient treated at UPenn, which for whom I think they did a recent story in the New York Times as well too. Just someone who has had essentially a cure because of the CAR T cells. So I think that's the The major plus is that it has a track record and it's somewhat specific. So people are very excited with that. The downside is that you have to collect the T cells and they have to be sent, and it takes a few weeks, and then they come back, and in the meantime you have to give more chemotherapy. And even when they come back, a person can have a period where you have the blood counts that are low, what we call myelosuppression. So that increases somewhat the complexity and creates certain infection risk and other things that one has to be mindful. So there's a recovery period. The bispecifics, on the other hand, as I mentioned, they're off the shelf. So you could imagine there's a pharmacy, and it could be in a community hospital. It doesn't have to be a specialized hospital. I think people are rightfully concerned that they want to see more follow-up of the depth and the duration of those responses. And the other one is that, they required repeated administration. So it's not going to happen in a one-off. It's something that, will require repeated treatment. So that's another, disincentive. I think whichever way it works out, whatever is the winner, it will be, embraced by patients. And there may be more than one winner, which is a great news because, with the bispecifics, not all of them target BCMA. Some of them target other molecules, GPRC5D, FCRH5. So as you notice, I have to study all of those. Those are all new targets for some of these antibodies, SLAMF7. So maybe someone fails a bispecific, but can go to a CAR T cell or vice versa.
You make such great points, including, one, there doesn't have to be just one winner. It could be multiple winners. And another with the BiTEs being possibly more available for the community hospitals, which I think would be a huge win, of course, for the many people who don't live near a Mayo Clinic or another center like that. With patients hearing about the excitement of, say, the bispecifics or BiTE, how soon do you think, ballpark are we thinking that might actually be available for people?
I don't know. It's a great question. We just had our first CAR T cell approved this year. Hopefully the next one pretty soon. We just can't get enough production capacity. I mean, it's really just gut-wrenching right now because we have waiting lists and just people who really want to get into this. We're opening as many clinical trials as we can, so we have this available for patients. And the bispecifics are still somewhat early on, and it depends on what level of evidence is required by the regulators. I mean, my sincere hope would be that they are available by next year, by 2022. Some of these trials are already treating hundreds of patients. We have precedence for this with other treatments in myeloma. So it would sound just almost science fiction, but it's possible that in 2022, we would have like 2 CAR T cells and 3 antibodies that are going to be available for the treatment of patients.